Well, welcome to all of you who are able to join us today for our fifth Lunch and Learn discussion. We are using these sessions to disseminate high voltage primary care research to an array of stakeholders. For those of you who may not be familiar with the Primary Care Collaborative, we are a nonprofit multi-stakeholder organization that focuses on strengthening primary care and helping to reinvent it. I'm Ann Greiner, President and CEO. Today, we've got a great lineup of speakers from organizations that are critical champions in the primary care space and organizations that we work with regularly. Harvard Medical School and the Harvard Center for Primary Care, the Alzheimer's Association, and Virginia Commonwealth University, particularly through a partnership with the Larry Green Center. I also want to welcome our two co-chairs for our Lunch and Learn series. For those of you who are regular attendees, you recognize them. Dr. Irene Donka-Mullen, who's Deputy Chief Officer at IBM, and Jack Westfall. Dr. Westfall is Director of the Robert Graham Center. We're continuing these Lunch and Learn sessions through the balance of the year. Our next session is on July 21st from 11 to noon, so please mark your calendars. And now let me turn over the baton to Noah Westfall, who is PCC staff lead on this project. Noah.
All right, hello everyone. Thanks again for joining. So I just have a few announcements before we get started. So just as a reminder, we have recently launched this research hub on our website, and it includes a list of 24 primary care articles. And so I wanted to make sure that you all knew that the two articles that we're going to be discussing today are on that list. And so I encourage you to please, visit that research hub section on our website and share with your networks. We hope that you will be able to explore some of the resources on that section. And then a few other reminders. We are a growing group, and we hope to make these sessions as interactive as possible. So if you are able to, we encourage you to turn on your cameras. And then during the discussion sections of the meeting, if you have any questions, please put your questions in the chat, and I will be helping to monitor the chat when we have our Q&A session. All right, so I would like to turn it over to our first article presenter.
Hi, this is Jack Westfall. I'm not going to present the first article, but I will introduce the speakers for the first article. It's great to be here. Thank you, Anne. Thank you, Noah. Thank you, all of you, for attending. This first article is Primary Care Physician Perspectives about Antipsychotics and Other Medications for Symptoms of Dementia. This article caught my eye when it came out because I was faced with this in my own practice. And I was so glad that the group that curated the 24 evidence-based articles included this one, because I think it's both important in its own right, and then I'll be asking a question about how this impacts the broader sense of how primary care interacts with research. It's my pleasure to introduce the co-speakers on this, Dr. Bill Kerns, clinical professor at Virginia Commonwealth University and medical director of Front Royal Family Practice. He has contributed to many projects in the Virginia Ambulatory Care Outcomes Research Network and has presented at many research conferences, including the North American Primary Care Research Group. Dr. Kerns works to make research interesting and germane to patients and the broader community by investigating, evaluating, and supporting the meaningfulness of national and regional statistical data, partnering with resident physicians to improve community health interests and health metrics, and regional health systems. Dr. Winter, as Associate Clinical Professor at VCU, Virginia Commonwealth University, and a Managing Partner at Front Royal Practice, He was raised in a large family in rural Western Maryland. After medical school at Johns Hopkins, he stayed in Baltimore for residency in family medicine at Franklin Square. He has a full spectrum family practice, including hospital, ICU, and maternal and child deliveries and care. I'm going to turn it over to Bill, and we'll go from there.
Wow, it's interesting to hear yourself put in that vein. Thanks for putting the slide up, Noah. First of all, thank you guys for asking John and I to be here today. We're thrilled to be here, a little scared to be here, and I think it's very cool that what the collaborative is pulling off. Certainly want to give a shout out to Tony Kuzel, whom most of you or a lot of you probably know. Tony, the former chair at VCU Department of Family Medicine, helped us to get the VCU grant that you see there. And Becca Etz, just a wonderful person, close friend, wonderful qualitative mentor, and certainly our project couldn't have occurred without that assistance and guidance. Also, just want to preface that before we did this study, we actually did a similar study with caregivers of nursing homes patients, and the nurses in the nursing home patients, the same in assisted living facilities and in the community, asking similar questions, but asking them those questions helped to guide questions we wanted to pose to primary care physicians. Now, if you can go to the next slide, and I'll let John kind of riff on why we wanted to do the study.
So we know the behavioral and psychological symptoms of dementia, which are non-cognitive dementia symptoms like agitation, paranoia, and combativeness, are common in all forms of dementia. In fact, it's these behaviors rather than cognitive symptoms of dementia that are often the most intrusive, hardest to manage, and most associated with institutionalization. Like I said, these symptoms are very tough to handle, and historically and currently, we've over-relied on risky medications to treat them, namely antipsychotics. So Bill and I's research is born from the question of, if data says that these risky drugs don't work well, and if we know these drugs definitely have severe risk for harm, particularly in fragile seniors, then why do we as rational and commonsensical clinicians continue to use them at such a high level? So that was the basic fundamental question that we were trying to get to the bottom of, because we felt that the answer to that question was key to moving forward and improving dementia care.
Okay, Noah, next. So the strength of our study, we think, is that we talked to about 60% of the adult primary care workforce in our health district in Virginia, Northwestern Shenandoah Valley. You know, the strength of a study is also its weakness, right? So we obviously our findings may not pertain to other areas, but we did talk to 10 general internists, 16 family medicine doctors, a number of whom did have several patients in nursing homes, pretty much all of whom saw patients who were in assisted living facilities. And of course, everybody did also treat people in the community. And we tried to do a sub-analysis to differentiate these folks, but really pretty much all of them said very close to the same kind of thing. And what we came up with is that they told us that, you know, non-medication efforts were hard to use because getting home caretakers trained to use them, getting them informed as they went along, and of course, informing a caretaker about how to help somebody today will be different when their disease progresses. And then the staff in the nursing home was difficult because there's a fair amount of turnover, and keeping people trained and up to date was hard to do. They felt that the evidence for these things, it just wasn't the randomized controlled trials that they were used to looking at. So they didn't think the evidence was that wonderful. And they were frustrated by the fact that it seemed to be situational. You would have an article that said that touch therapy helped in a particular nursing home in a particular situation, or at least that's how they read the data. And lastly, I mean, no matter who you are and how trained you are, there are times with dementia patients that non-medication things don't do the job. Whereas for medications, it was easy. You know, yeah, you may have to change a diagnosis, you may have to fill out a form every month, but other than that, and in the office, you didn't have to do any of those things. Medications, depending on which one, weren't that expensive. They were easy to write. They were effective. People felt that they were 50% effective or more when, you know, the data from the randomized trials doesn't support that. And they also felt that the medicines were as safe as any other medicine they gave for those symptoms, primarily falls and sedation. But they really didn't see the dire consequences that are mentioned in the black box warnings. And we can talk about that later if you want to, as to why that might be. They also felt that their use of antipsychotics and other medicines was incredibly appropriate and patient-centered to relieve distress, to help with agitation, to help with functionality, to keep people at home, to keep people in the assisted living facility instead of in a nursing home. And at the time, I don't know if after COVID it still is, but you know, the number one cause of death in the United Kingdom is dementia. I mean, dementia is a terminal illness. And so they felt they were giving them palliative care, similar to how you might give somebody with cancer morphine and not worry about it as much. They found that the guidelines, especially for non-medical things, weren't that helpful. Mostly you needed to develop a potpourri of different methods that you could kind of apply, and they didn't find that there was any particular structure to that that they could find. And if you needed to use the medicine, the advice was very general. And at the time of this article, about half the guidelines seemed to indicate that unless the patient was a danger to themselves or others, you were totally inappropriate in giving the medicine. So they felt like they were being called bad doctors for using the medicine ever at all. So for the next slide, please, Noah. So these are our conclusions. You know, certainly we need to advocate and insist with our policymakers and locally. I think one of the takeaways for me was you need to be advocating in your own nursing home, in your own community, in your own practice for people to be well educated about non-medicine avenues, as well as for how to use medicines when they were absolutely necessary. But, you know, if you're going to advocate that, gee, these are the things you ought to do, they need to be actually available and affordable. You know, and we need better guidelines to try to figure that out. And I hope Morgan in a minute is going to help us to understand how we can be part of the guideline development effort. The thing I really learned from this study is it's kind of like we have dozens of medicines for hypertension. When you're using non-medicine approaches for folks with dementia, it depends on the time of day, it depends on the state of disease. And of course, you need to make sure that they don't have any underlying reason why they became more agitated. But that's step one. So for step 2 and 3, you need to just make sure that you can have enough knowledge of these avenues that you can kind of do what Dave Slauson used to call clinical jazz, where you can kind of riff on what you should do and when you should do it, and be very flexible and ad lib it as you went along. John, what would you add?
Yeah, I think you summed it up well, Bill. I think that barriers exist to non-pharmacologic measures that just don't exist for drugs. Drugs are cheap and easy and available, and all the non-pharm measures are time-consuming, expensive, and not covered by payers. And so I think that first line in your conclusion is perfect, which is that if we're going to move forward, we need to have these measures as affordable, available, and with the proven efficacy as drugs. We all intuitively know that these interventions work a lot of the time, but payers have a mandate to only cover things that reach a certain standard of efficacy. And so I think that there's a reason that CMS will not pay for certain interventions that we'd all like to see in nursing homes and in communities. So we need to be advocating for more efficacy evidence being generated from the research community. And again, it was super interesting to me that if the data says one thing, the data says the drugs don't really work, and the data says these drugs are risky, that when you talk to caregivers, you talk to nurses, you talk to doctors, they say they work and they say they don't see the side effects. So there's a super interesting mismatch between what folks in the trenches are observing and what data says. And I think to some degree, it gets to when you're dealing with a population with a very high prevalence of adverse outcomes, that detecting an increase in adverse outcomes is hard for clinicians to detect.
Bill and Jonathan, thank you so much. That was fantastic. I'm going to turn it over quickly to Morgan Daven from the Alzheimer's Association to give his reflections on this conversation.
Okay, so thank you so much, Jack, and thank you, Bill and Jonathan. And I'm with the Alzheimer's Association as Vice President for Health Systems, so leading our work with clinicians and health systems in the US. And I've worked with primary care practices and doctors for 27 years now. So I'm not a primary care doctor myself, but dedicated to how we can work on dementia care in a way that is really beneficial for those who are living with this disease, their caregivers, and for their primary care clinicians and care teams. So I think there's a lot here, a really excellent article. And, I want to frame this around we're all working to do truly meaningful person-centered care. And this is one of many instances where there's a lot to talk about. How does that actually happen in practice? A lot to talk about here in terms of the barriers and the limitations, and also opportunities. So really appreciate what you've put into this article and what you've shared today about it. So from my perspective, I'd say, we agree with you on really the gist of what you've put into this article. Agree that non-medication interventions can be effective if the primary care team are trained and have access to the resources needed. Agree about the potential side effects and dangers of antipsychotic medications, and also agree that sometimes they are needed and can be effective in certain situations. We agree that a person-centered approach, we really advocate for that and try to help support that with tools and guidance and resources. We provide person-centered recommendations for the clinician, and we'll say more about that in a moment, and also resources for the person living with the disease and their caregiver. We at the Alzheimer's Association, generally we're recommending trying the non-medication interventions as the first line of defense, with these medications, including antipsychotic medications, considered only after trying non-medication options. And some of these options can be effective. As you mentioned, there is limited but growing evidence for some of these non-medication options, such as outdoor activities, massage, music, and these can be selected in a person-centered way, knowing the person and working with their care partner and caregiver. When it comes to medications, certainly with antipsychotics, but with all of these medications, of course, the importance of medication review and dosage, being very careful, of course. Don't think there's any disagreement on that. And to continue these as only as long as necessary. So medication review and coming off of medications when indicated as well. Certainly agree with you about these barriers. There are significant barriers here. There are barriers to accessing resources around some of the non-medication treatment options. And primary care clinicians and their teams do need more training, more education, more resources on non-medication options. And we also, as you mentioned, Bill, we agree that primary care physicians should be involved in guideline development and certainly advocate for that. One other note is that all of this also does add to the case for timely detection and diagnosis of dementia and even cognitive impairment, really woefully underdiagnosed, especially in a timely way. Only about half of those who have dementia have a diagnosis. So early detection and diagnosis is important so that primary care providers and their teams can work with the person who has the disease and also with their care partner early on. There's a through line here longitudinally over the progression of the disease where these non-medication interventions can be useful at many, really many stages of the disease, including very early on, and helping that care partner or caregiver play an active role with some of those interventions.
Morgan, thank you so much. We really appreciate you being here and responding to this. It's really a crucial part of this conversation, this lunch and learn. We really want to stimulate the conversations around these curated articles that disseminate. And I think there's a number of questions that I've already received, and so I'm going to just jump in. And I think we can go to so I'm curious, sort of the current, this is for Bill and Jonathan and you too, Morgan, but I'd be very curious from a clinician standpoint, what's sort of the current, this paper came out a few years ago, and what's your current sense of use of medications, the consideration for unintended consequences of the warning labels related to this, and the consideration around being labeled as sort of a bad doctor if you choose to use these medications. I'm curious, sort of your response in 2022 about that.
There's a theory that these medications are used as a crutch by facilities that are under-resourced to provide non-pharmacologic measures. And we know that over the pandemic, all staffing resources and resources in general have been squeezed. So early data is saying that over the last 3 years, the trend we saw towards a decreased use in medication, that there has been an uptick of those over the pandemic, probably for a number of reasons, including, loss of community resources and facilities being closed to a family to come in and help provide non-pharmacologic interventions. As far as unintended consequences for the important and meaningful measures that have tried to reduce the over-reliance on certain medications, particularly risky antipsychotics that we've seen, is an increase in alternative medications that do not have the same level of focus, namely mood stabilizer medications like Lamictal and Depakote and Tegretol as a non-superior, equally unsafe alternatives to antipsychotics, but not reaching the same level of attention. Again, I have this feeling that when we try to reduce the reliance on an affordable and available option and don't provide resources for the alternative, that you get a separation in facilities between the haves and the have-nots, or facilities that exist in communities with more resources, that have better payers, that are more desirable, that have the luxury of being able to choose the residents that come in, versus facilities that don't have those, that again, you start to see this separation. And I believe that we're seeing that in Virginia nationally, is that if nationally the antipsychotic rate is 14%, that in the top and bottom quintiles is 30% and 5%. And so you get this separation that I believe is starting to occur between certain facilities and others. And I think getting to the bottom of that is going to be really interesting. And the early data says it follows resources and social determinants of health.
Jonathan, thank you. I have a question for all three of you, and there's been a number of people who've raised this, and it's about this disconnect between the evidence-based guidelines and the clinical experience of clinicians who report that this is effective and safe, but the evidence says it may be not safe and effective, and the guidelines have a particular then recommendation. And I'm curious about one of the exciting things for me on this is I'm a translation guy. And so to have two physicians who are in practice publish an article and be here to present is really exciting. And so I'd ask you two to sort of give your opinion on the broader context of your work informing both this particular topic, but also as primary care, how do we get your input in all sort of recommendations and guidelines? And then from Morgan's perspective, how does the Alzheimer's Association think about engaging people like you in the creation of their guidelines and recommendations? So Bill and Jonathan, and then Morgan, if you can.
Let me just add a little bit to what John has already said, in that I think in the article you'll find we cite a 12-week study of starting antipsychotics versus folks who didn't get the antipsychotics. And besides the notion that those two groups may not be the same, you'll find the survivorship was, like, in one group was 96.3 and the other 97.2. I don't remember the exact numbers, but they were definitely different, which if you look at the numbers, you know, we're used to studies talking about absolute risk reduction, or actually, you know, relative risk reduction. The relative risk reduction is substantial. The absolute risk reduction is not. And if you're, as John said, dealing with a frail population that, you know, even without antipsychotics has a mortality of, you know, 2-3% over that period of time, seeing it go from 2 to 3% to 3 to 4% is, I mean, if you're a clinician, that's impossible to see, or you certainly aren't going to be seeing that. It depends on whether you talk about survivorship or risk reduction, and very two different statistical things. John, what would you add?
I think that's a really interesting question, Dr. Westphal. I think it was fascinating to me to talk to almost 100 people, including family members and caregivers and nurses and physicians, including nurses and physicians with decades and decades and decades of experience, and have not a single one of them ever admit to knowingly see the severe side effects that we all are concerned about with these medications, even though the data says that they exist. I think it's super fascinating. And I from a global perspective, I think it gets to some of the challenges of shared decision-making. We've all had discussions with families about whether or not to do chemotherapy for a particular cancer. And you can talk about relative risk reduction and absolute risk reduction, and you can make two arguments that go in a different direction. It's really challenging. And one thing that's been very positive for me over the last 5 years is I do feel like I see guidelines incorporating the input of multiple stakeholder groups. I think 5 years ago, when we were first looking at this work, there was a feeling that potentially the perspective of caregivers and patients, particularly those who have a very palliative-oriented philosophy of care, that their perspective were not being included into these guidelines. So if a family member said our number one priority for our loved one is to keep them in their own home, how does that consideration go into whether or not you use a risky medication when a guideline says only when there's a risk for severe harm or death? So I don't know, it's an interesting philosophical thing to look at and consider.
Thank you, Jonathan. Morgan, I'm gonna let you have the last word on this before we finish up this section of our Lunch and Learn, and then we'll move on to the next article. Morgan?
Great discussion. So for the Alzheimer's Association, absolutely important to involve primary care clinicians, primary care in the guideline development, and also those who are affected by the disease to have expertise, scientifically based, but also perspectives from those affected by the disease and caregivers. But certainly for primary care, that's just essential. We really have so many deficits in terms of the way that scientific advances in dementia are really applied and helping to equip physicians to apply them. So there's a lot to be glad about in terms of increases in federal funding for Alzheimer's research, basic science, et cetera, advances in diagnostics, and things are looking up in terms of when you look at classes of drugs for potential treatment. There's so many gaps, though, in terms of health services research, translational research, and guidelines that are developed, with primary care as part of that development. So we at the Alzheimer's Association certainly advocate for that. We're also advocating for payment models that are really appropriate to what it takes to provide dementia care, including in primary care, which is the front lines of dementia care. When you look at the really severe limitations in terms of specialists who are available, and for a disease that's in some ways still looking for a specialty. So primary care is really where most of it needs to happen. I do want to mention just quickly our ECHO program. It was the first resource that I had offered that was put into the chat. We do ECHO for primary care and for long-term care. And this is one way, not the only way, but in addition to other CMEs, this is a really case-based interactive way that takes what's in the evidence and having a team of clinicians working with primary care physicians and their care teams in terms of real life case-based application. That's one way to really combine what's in the published evidence and in the experience of clinicians to provide good patient-centered, person-centered care.
Morgan, thank you so much. We're going to move on. There's a bunch more comments and questions in the chat, and I hope that Bill and Jonathan and Morgan, you will take a look at those and consider responding to those directly. But we're going to move on, and I'm going to turn it over to my co-facilitator, Dr. Mullen.
Awesome. Thank you. I'm also delighted to be here, and thank you all for joining and participating. I'm just excited about the second paper as the first article, and I hope that we'll have an engaging discussion. So I am also thrilled to introduce our next speaker, Dr. Bruce Landon, who would be discussing another seminal article, Estimated Effect on Life Expectancy of Alleviating Primary Care Shortages in the United States. Dr. Landon is Professor of Healthcare Policy at Harvard Medical School and a Professor of Medicine at the Beth Israel Deaconess Medical Center, where he also practices internal medicine. He received his MD from University of Pennsylvania School of Medicine and an MBA with concentration in healthcare management from Wharton School. He's a fellow of the American College of Physicians and an elected member of the American Society of Clinical Investigation. And his primary research interest has been assessing the impact of different characteristics of physicians and healthcare organizations, ranging from health plans to physician group practices on physician behavior and the provision of healthcare services. And he's also been very interested in the area of payment reform and has been involved in studying both global payment strategies, such as Medicare's Accountable Care Organization program and payment systems for primary care. So I will hand it over to Bruce for the next presentation.
Excellent. Good morning, everyone, and thank you very much for that introduction. I'm really delighted to be here. And have to say, you guys have done a great job in putting together two papers that really show the breadth of research in primary care. I mean, moving from something that was very clinically oriented, qualitative, really has to do with what we do every day with our patients, to what I'm going to be talking about, which is much more high level, policy oriented. And I think this really demonstrates the breadth of research that we do in primary care. And I really am grateful to be involved across that spectrum. So can I have the next slide, please? So I put this slide up just to show a familiar picture that many of you who are involved in primary care research have probably seen, over the past decades. There's been a long history of research in primary care that basically has leveraged what we see here on these slides, which is differences in the primary care supply or orientation of different parts of our country And this has also been done internationally by Barbara Starfield and others, and looking at how primary care supply and orientation correlates with outcomes of the healthcare system. On this slide, we're actually also showing you specialist supply. And in fact, I'm showing you how the two of them have changed over the time period from 2005 to 2015. You'll notice that on the left, the primary care physician density map looks a bit darker than the one on the right, the specialist physician density map. That really suggests that we continue to lose primary care physician supply in lots of areas of the country. Next slide, please. So there's been a lot of research that has leveraged those sorts of data that really taken together show that primary care physician density has been linked to lower morbidity, mortality, and improved life expectancy. One of these papers I note here on the right was a prior presentation in this series, which I believe Sanjay Basu presented, maybe even leading off the series, where we leveraged the longitudinal data that I just showed you to really show in a causal way that changes in primary care density really are associated with mortality for patients and life expectancy. As a result of these data and others, there's really been multiple local, state, and federal initiatives that seek to address these shortages. I mean, these include things like the National Health Services Corps from HRSA. People are probably familiar with the fact that there's, several new medical schools that have been launched that are explicitly trying to train more primary care doctors. This includes NYU, Long Island, Florida State, among others. And those are investments by states for the most part. We also are aware of many local areas where they're actually putting in community resources to try to recruit physicians. And what we don't know really well is what is the payoff to increasing density? And that's why we did this study. So next slide, please. So our study objective was to estimate the impact on life expectancy from alleviating primary care physician shortages in underserved areas. It's not the next slide, but enter, please. And this is the paper. It was actually published about a year ago in the Annals of Maternal Medicine. I actually see one of my co-authors, Bob Phillips, on the phone, and I'm surprised he's not the one presenting. So next slide, please. So I'm going to take you through this study a little bit because it's a little bit complicated, and I'll be happy to answer other questions about it, obviously, as we go along. So our primary outcome was changes in life expectancy at birth using estimates from a small area model developed by the Institute for Health Metrics Evaluation at the University of Washington that would be expected from alleviating shortages in primary care supply. And as secondary outcomes, we also looked at all-cause and cause-specific mortality in the areas I list here. Next slide, please. So our key independent variable measure was primary care physician density per 100,000 each county. And this was available from the area resource file. And we use as control variables, I don't list all of them here, things like the number of specialists in the area, the rural-urban continuum score, socioeconomic status, age, race, ethnicity, et cetera. And all of these were measured in the same way in all the counties in 2010, 2015, 2017. So we again take advantage of the longitudinal nature of these data. Next slide, please. So to define shortage areas, we actually looked at two different cutoffs. The first one was the official HRSA definition for identifying health profession shortage areas, which is defined as a density of one primary care physician per 3,500 population. Turns out across the country, about 1,218 counties met this definition in 2017. That's out of just over 3,000 counties. So this is actually very, very prominent. Now, there's also an alternative definition that we considered, which is less than one primary care physician per 1,500 population. This alternative threshold was suggested by the negotiated rulemaking committee organized in 2010 by HRSA and presented to the Secretary of HHS, but it was actually never kind of acted upon. And you can see here that actually the vast majority of counties in the United States actually fit this definition. Next slide, please. So getting to some of the results. So I first wanted to just show you this very simple graph, and these are adjusted outcomes, looking at the relationship between age-adjusted life expectancy and PCP density. And if you kind of squint at this, you can notice that that line is actually not a straight line. Rather, it's a little bit S-shaped. It starts out a little flat, it's steeper in the middle, and it ends up a little flat. And because of that, that really informed our primary modeling strategy. So next slide, please. So Here I'm going to show you the main results of our study. So in the left-hand column, you can see what would be expected, the expected change in life expectancy if we alleviate primary care physician shortages in officially defined HPSA counties, less than 1 in 3,500. And here you can see that the life expectancy on average in those counties would increase by about 22.5 days. Doesn't sound like a huge amount, but it actually is a huge amount when you look across populations. However, if we look at alleviating even, in counties that were more common, where we alleviate shortages up to 1 in 1,500, we actually see a much stronger effect, an increase in life expectancy of 56.3 days, and that's across a much larger population, a much larger number of counties. You can also see that, not surprisingly, our secondary outcomes all show consistent results. If you're going to live longer, it means you're going to die less frequently. So we see improvements in all cause as well as cause-specific mortality. And you can again see that same graded effect where the effect is actually bigger in the middle of the range than it was at the lower end of the range, which to me sort of suggests that down at the bottom end of the range, if we go up to the 1 in 3,500 threshold, it's really not enough to move the bar or move it very much, but it certainly can move it if we go to even higher levels. Next slide, please. So this shows the projected number of averted deaths. You can see if we use the first threshold, the number is actually relatively small. It's on the order of several hundreds per year. If we go up to the 1 in 1,500 threshold, it's on the order of 7,000 per year. And that doesn't sound like a lot in a country of 320 million. But obviously this is per year, so this will be a cumulative effect. And there's probably lots more effects than just looking at mortality. Next slide, please. So how many physicians would it take to actually, fix these shortages? So if we alleviate the shortage in the formal HPSA counties, that would require another 17,000 additional physicians, or 14.5 per county. If we go to the lower threshold of 1 in 1,500, that would require almost 100,000 more primary care physicians, or 36.3 per county. Just to frame that a little bit, there's only about 250,000, maybe 200 to 250,000 primary care physicians in the country now. So having another 95,000 would be quite a big ask. Next slide, please. So the conclusions we drew that clearly increasing the PCB density will result in improved life expectancy and survival. And it's actually more prominent when we go up to higher levels of density. So it's not just at the low end of the scale. Increasing density to the 1 in 1,500 threshold is a better return, but seems unlikely given that there are over 900 areas of the country that were underserved across the entire study period that we looked at. And I think these data also suggest that HRSA should consider going back to those 2010 rulemaking and consider updating its official definition of HPSAs. Next slide. So that's all I have. Thank you very much for your attention. Happy to take any questions.
Oh, terrific. Thank you so much for your fantastic presentation. This is sort of clearly, linked with our previous discussion. I do see we have some questions that are beginning to come in. So this is a question from Richard Young. How do you correct for the inherent inaccuracies of the AMA master file for counting primary care physicians?
So that's a really important question. And I agree that there are definitely inaccuracies. And in research like this, where we're using large databases and big data, the really important question to ask is not how accurate it is, but to what extent is it going to lead to biased results? So what I mean by that is if it was going to lead to a biased results in the sense that we would find an answer that was different than the one that we saw, then that's a really big problem. The inaccuracy itself is what I would sort of, we can kind of in a simple way refer to it as noise. So that's statistical noise. And in general, inaccuracy or misclassification would end up biasing results toward the null. In this case, we don't see null results, and I don't see any reason why those inaccuracies that you're referring to would actually bias our results in one direction or another. So given those inaccuracies, you could almost look at these results as a floor because we know that there's a bunch of misclassification.
Thank you, got it. And this follow-up question, well, did the study include pediatricians as primary care physicians, or was just internal medicine and family practice?
So in this case, we actually focused on adults, so we did not include pediatricians. It's also interesting to note, so, I've been in lots of discussions where we've tried to bring together primary care specialties, including, family medicine, internal medicine, sometimes osteopathic medicine, and certainly pediatrics. And the discussions are very different. Whenever we sort of say, oh, there's this bad shortage of primary care physicians, the pediatricians tend to raise their hand and say, no, that's not the case in pediatrics. We're doing just fine, thank you. And when we talk about sort of the work life of primary care physicians and burnout and dissatisfaction and aging workforce, the pediatricians again raise their hand and say, actually, not so much for us, we're getting plenty of new pediatricians. So I think it's important that we did actually make that distinction, because it's not clear that the directionality would be the same. And I do believe, however, that it's likely that, we're looking at life expectancy of a full population. So pediatric, deaths would also influence that, but probably not the strongest thing doing that.
Mm-hmm. And those are a question about whether PAs, NPs, who also provide a growing amount of primary care services, whether they were included in the analysis.
So that is a really, really good question, and one which I unfortunately have to answer in the negative. So we were not able to include them. And the main reason for that is when you look at most federal databases, and this is the case for Medicare as well, it's pretty much impossible to delineate where APPs are practicing. I can't remember, in the first study that I mentioned on the second slide that I presented, we actually did a sensitivity analysis where we included NPs, I believe. And the reason for that is if you look across a spectrum of physician assistants, many more of them are practicing within specialty sites. Nurse practitioners are more commonly in primary care. So even though we can't actually tell their official specialty, it was more safe to look at them as a sensitivity analysis. But generally, I think the data looking at the APP workforce is a little bit lacking and needs to be better, but so we were not really able to include them.
Mm-hmm. Great. Lots of questions coming in. John has a question about, out of the huge range of services that primary care physicians provide, do you have a sense of the services that are most critical to impacting life expectancy? Or you probably looked at that.
So that is a really challenging question. And I would say from the research that we did here and in that other paper that I mentioned, we really don't get into the weeds about what is it about primary care that improves life expectancy. But I think if you look across the literature, and frankly, if you look across the 24 papers that were selected for this series, I think you can see some clues. And I don't know if Bob's on the phone, he can comment on this as well. But we know that things like continuity, and that's visit-based continuity and continuity overall, where primary care physicians actually know the patient and get to know all of their conditions and know what the patient wants, is definitely something that's been associated with improved outcomes. We also know that comprehensiveness of care, which is something that we're seeing erosions of over time, particularly in my specialty, internal medicine, more so than family medicine, but probably in both of those. Comprehensiveness is another thing that's been associated with improvements. So I think some of that other literature can give us some clues that our paper cannot.
Terrific. I think this is similar. So the quickly, the number of physicians counting, are you counting FTEs, or you are assuming that each physician is working full-time?
Yeah, so this gets at another issue that's a limitation of the data. And again, an error that would sort of lead more to misclassification than anything else. So the AMI master file data that we used, although there are questionnaires and whatnot, generally these things don't get updated all that often. So it's really hard to use that to try to figure out an FTE. So we basically count for one.
Mm-hmm. And then I think I did have a question, but Bill also, this is about how can we help, right? There are fewer graduates of both allopathic, osteopathic medical schools going into primary care, a smaller percentage of NPs, right? NPs over time also going into primary care. And given that, how are we going to be able to begin to address this shortage program? Even with, I think it's a huge question, but any thoughts on that? And
So I'd like to share two ideas on that. And one of them is actually additional data. So I'll give you a sneak peek of a paper that we have in press at the Annals of Internal Medicine, where we looked at career choices among internists. And I believe this would be not dissimilar if we looked at family medicine physicians. So over time, we've seen that graduating internal medicine residents are largely choosing to go into hospital medicine at a level of sort of 70 to 80%, and only 20 or 25% of them are going into practicing outpatient primary care. And one thing that people used to think was, oh, that hospital medicine thing, that's just going to be a temporary choice. Then they go on and do something else. So it turns out that the data show that that's not the case anymore. So that choice of hospital medicine is durable, and most of those physicians that make that choice stay there. What we found that was really interesting and relevant to this workforce question is that over time, it used to be that there were a lot of physicians that did both inpatient and outpatient medicine. So I'm an example of that. I used to take care of my own patients in the hospital, but after going on sabbatical a few years ago, I ended up having to give that up. And most of the physicians at my hospital basically had to give it up for a lot of reasons. And we've seen that we're not a standout. So this has basically happened across the whole country. So you used to see that there are a lot of physicians, particularly older physicians, who came out 10, 20, 30 years ago, who had mixed practices. And over the last 10 or so years, most of those physicians are now practicing only outpatient medicine. So what that served to do was to increase the supply of outpatient primary care without having more bodies. But we've tapped that, those physicians have already made that choice. So I actually think we're going to see an acceleration in workforce issues over the next several years, because we don't have that other source of other primary care physicians coming in to at least increase their volume. And it's absolutely true that very few medical students are choosing to go into primary care. What can we do about that? I mean, I think that's part of the mission of an organization like the PCC. Personally, I'm a strong advocate for payment reform. I think paying primary care for piecemeal work, as opposed to whole person care, really goes against what we're trying to achieve in primary care. And I think that's one place where we really have to change the paradigm and really support team-based care. And as we change primary care, it will become more attractive, but we've not made a huge amount of progress in that yet. I don't know if Anne wants to chime in. I see her nodding though.
I'd love the invitation to chime in. Thanks so much, Bruce. And I really appreciate all the research that's being presented here today. And I think also the NASM report that came out in May of 2021 that updates the evidence base. And I think this audience knows, but it bears repeating, that the one place in our health system, if we invest more, we get better population health outcomes and more equity, is primary care. So how do we change that? And I agree that payment is an important lever. The PCC has just launched a campaign called Better Health Now, and our focus is on changing how we pay and how much we pay so that we can improve the health of the nation. And primary care is an essential way to do that. And so check out our website, and thank you all so much for your contributions. We've got a lot of work ahead of us, but it's wonderful to have this community.
yes, thank you all. I think that's it. Again, thank you so much, Bruce, for your presentation. And I will actually turn it over to, is it Noah, who is keeping me in check?
Yes, thank you. And thank you again to our presenters and our co-chairs for a really great conversation. I just had a few closing reminders. If you could please complete a brief 2-minute meeting evaluation. This is one way for us to get some feedback about how the sessions are doing, and we want to present the research that you're most interested in. So we'd really appreciate you filling out the evaluation. And then another reminder is we have our next Lunch and Learn discussion on July 21st from 11 to noon. And I will be posting information about that meeting as we get closer to that meeting. So yeah, any final thoughts from Anne?
Well, I really want to thank our presenters and our co-leads for the Lunch and Learn series. We are, as Noah said, thinking about all different and creative ways to get primary care research out into policymakers' hands and also into practice leaders' hands as well. In addition, we're going to be updating our list to address some important gaps. So, this is a vital list of exemplary primary care research that we're continuing to update. And we hope that you tell your friends and networks about our Lunch and Learn series and come back and join us in July. And I don't know if Jack or Irene would like to say anything in closing. We've got a minute or two.
This is Jack, and I'll just say thank you. It's so exciting to see this range, and I think Bruce said this is such a great venue for the whole pipeline and the whole pathway, the whole breadth of primary care research, from what's happening in the practice to what's happening in the nation. So thank you all. And thank you to the PCC for hosting this and agreeing to sort of think about this in both a local and a national context.
Yeah, I would echo Jack's comments. Thank you all. I mean, it shows that there's a lot to do. I mean, I always also wear my health equity hat on and disparities. So you can imagine with COVID and the pandemic, how this research will play out with the glaring disparities. It means that there is a lot that we need to do and a lot to disseminate to our stakeholders. So thank you all, and look forward to hearing the next Lunch and Learn.